Good afternoon, everybody. Hi. All right. It's almost afternoon snack time. No. Um, Thank you so much for coming, and happy to be here. Thank you, Jen King, for hosting us here, and to the entire suicide prevention team for putting on the conference, and for all of us for taking our day to be here to talk about suicide prevention together. My name is Joyce Chu. I'm over there. So I'm a licensed clinical psychologist. I also am a professor at Palo Alto University, and do a lot of just consultation and program evaluation and research and teaching and clinical work and all kinds of wonderful things around suicide prevention. Identify as professionally as a cultural psychologist, also as a community psychologist and a suicidologist. And it's my huge pleasure to be here to talk to you today about the Be Sensitive, Be Brave training. So how do you address diversity in suicide prevention through culturally infused community helper trainings? I'm just curious, how many of you are actually here to learn about the Be Sensitive, Be Brave trainings themselves? No? Okay, how many of you are here to learn about how to culturally infuse community trainings? Okay, a lot of you. All right. So that just helps me. I wasn't exactly sure how many folks wanted to hear specifically about BSBB. So I'll try to do as much as I can about, I'm going to be talking about what is called the Be Sensitive, Be Brave trainings. But so you'll probably learn a lot about BSBB that you may not, more than you may have wanted to know. But I invite you, as I talk about BSBB, to see how we approach cultural infusion for community helper training. Because I think there's a lot of ways of that approach that can be transferred over into just different trainings that you might be also trying to do and implement in your community. I first want to give a huge shout out to lots of different partners. This is the creation of these culturally infused community helper trainings was absolutely a team effort. First and foremost, Community Connections is just the group practice that me and Chris Weaver, that's where we do a lot of our passion work around suicide prevention outside of Palo Alto University. Huge shout out to County of Santa Clara. You'll see that together, it was the brainchild of the Santa Clara group and me and my colleagues as well to create a culturally infused community helper training. And also San Mateo County, you'll hear a shout out to San Mateo County, has been a huge partner in making these community helper trainings happen. And these are just a list of the different counties across the state of California that are now using culturally infused community helper trainings in the form of BSBB or others as well. So let me just orient you to the issue. I first started one of my professional life missions is to make diversity and culture infused throughout everything that we do in suicide prevention. The original reason why I got into suicide prevention is just because I identify as Chinese American. My parents are first generation Chinese immigrants, and mental health just wasn't a thing in my community when I grew up at all. I didn't even realize what it was. Certainly, when I remember when my friend, and when I was growing up, was seriously suicidal, and we had no idea what to do, nor did anybody in my community know what to do. And we had folks who had serious mental illness in my family that I didn't even know existed until I was 17 or 18. And so when I went into psychology, that is really what I wanted to do, was just decrease disparities and increase access for different communities of color and LGBTQ plus communities. And we have so much work to do to be able to give folks the access and the services and the help that they need when they're feeling suicidal. And there's many, many folks who are suffering in silence. And these community helper trainings, I think, are just a huge avenue and reason why we need to do that, because a lot of, for example, what we do know is that for Asian American communities, for whom Asian American mental health has a huge place in my heart. Oftentimes what we think is happening is that when somebody is in distress and they're from an Asian American community where things aren't talked about, on average, they reach out to one person, and on average, that one person doesn't know what to do. And they effectively kind of just listen, they may say they may not know what to do, they may say things that aren't really supportive, and then they certainly don't suggest that somebody gets connected to resources, and then effectively the whole seeking pathway would stop right there. And realizing that might be the reason why Asian Americans have the lowest rates of service utilization in the United States, and has been that way for over 20 years, is why I think community helper trainings are incredibly, incredibly important. When I first started doing this work was back in 2008 or so, and I realized we need to think differently about diversity in suicide. We had been doing a lot of efforts here and there, and it just wasn't moving the needle. And people still were getting services, they were going to trainings, and they weren't seeing themselves in those efforts. And when you don't see yourself in that effort, or you're talking to someone and you don't feel like you're connecting, then you're just not going to continue on with that path, with that conversation, with that support. And for a long time, suicide prevention was thought of as something that wasn't really affected by diversity, because if you look at just aggregated data, you see that the highest rates of suicide are in white middle-aged men. So a lot of folks said, well, this is not a diversity thing. And then for many decades just kind of moved on. Not only until maybe 7 years ago did that start to shift a little bit. And when you disaggregate that data, you actually see that there are a lot of cultural groups at elevated risk. If you look at all US data, 65 years and older for women, and particularly 85 years and older, the highest risk group with the highest rates of suicide deaths are in Asian American women, Asian American older adult women. The highest rates of suicide death of any community of color is in Native Americans. That's even higher than white individuals in the general population. Those rates for older adults, am I pointing in the right direction? I think so, mirror the highest rates of suicide in the world are from Asian countries, starting from South Korea, followed by China, Japan, and India. And when you look at suicidal behaviors, meaning ideation and attempts, we're really concerned about some rises that we're seeing in some Black and Latina adolescents. And other at-risk populations, including military populations and veterans, where we see as many as 20 suicide deaths per day, and LGBTQ plus populations, we have little to no actual data on suicide deaths, but we see very concerning rates of suicide risk and ideation and attempts in LGBTQ plus populations, particularly transgender and gender non-binary youth and adults, where we're seeing anywhere from 40 to 80% of folks having attempted suicide. And so hopefully this data really shows you, yes, it is a diversity thing. Culture and diversity are absolutely something that we need to think about. But when I first started doing this work with colleagues, we looked around and we saw very much the same old thinking with the same old results. So we would use the same brochures, the same lists of warning signs, the same checklists, the same questions that we would ask over and over. And as a clinician, I was literally taught to ask questions about suicide like a robot, so that I could get it out and not be anxious about it. Are you having thoughts of killing yourself? And then we would practice that over and over. Well, what if that question doesn't fit somebody and they don't, either that's too stigmatizing to hear it that way, or they might think of it in a totally different way. And I'll give some examples a little bit later. But that was my critique, is that, we really were kind of one note around that with very little recognition of cultural variation, cultural context. And when I looked at, the fact that as a clinician, I wasn't seeing culture and diversity integrated into my training, in training of others around me, I said, well, what about in our public health and upstream suicide prevention efforts? What about community? What used to be, and probably still today is known as gatekeeper trainings, right? So that's question, persuade, refer, assist, safe talk, cognito. The reason why I'm putting huge quotes and encouraging and not using the word gatekeeper is that when we pilot tested the community helper trainings, is what the term that I'm using, with the transgender and gender non-binary community. The feedback was that the word gatekeeper is just very, very triggering because of the role of mental health providers as gatekeepers to accessing gender affirming care. And so that word is something that I think is just an example of how we've been using and still use, the vast majority of the suicide prevention field still uses suicide gatekeeper training, a term that actually from the very start is not welcoming, and is actually triggering and traumatizing for a cultural community. So I looked at, we said, well, how are we doing with culture and diversity infusion into community helper trainings? And what we saw was that a lot of those trainings are pretty generalized with minimal attention to culture. It primarily uses a Western lens and a Western context, and I can give you some examples of that a little bit later. And there's some data that also points to a need for attention to culture. So when folks actually, there is some research that evaluated some of the helper trainings out there and found that, when you, for example, deliver a training to a Native American community, some of them are neutral. They're not doing harm, but there are some data that it is actually less effective for communities of color compared to general population. And two of my critiques are that we've had lack of application and a piecemeal rather than infusion into our existing community helper trainings. And I want to talk about that a little bit more, about these two particular gaps that has gaps for kind of infusing culture and diversity. And you'll hear me use that word a lot, of infusing, because I really do think that oftentimes, we put a cultural module, we stick it at the end. That really doesn't help to speak to culture and diversity throughout every single part of suicide prevention. And so that's why I prefer the term cultural infusion. So the first barrier I call just a stall at awareness before getting to application. So let me see if I can illustrate what I mean with it. Just a metaphor. In my role as a parent, I have a 10-year-old and then my son who just turned 12. And so my spouse is not in mental health at all. And I think he thought, jackpot, I married someone who's a psychologist, like she's going to take care of it. Awesome, right? And clearly, I would be much more, as a psychologist or a mental health professional, way more qualified to be an amazing parent, and our children would be so mentally healthy and thriving. And that turned out to be a delusional thought. And actually I had to educate him out of that, like every month. He'd be like, so what do we do? I don't know. What do you think we should do? I don't know. You tell me. To me, it really felt like, I looked around, I got a lot of messages, very coined terms like, I need to be supportive. I need to have a growth mindset, autonomous parenting. And if I did that autonomous supportive parenting, surely, I felt like, gosh, I can't be a superhero. And that's what it felt like, that I was supposed to, as a psychologist and a parent, be able to do all of those things and know what that looks like on an everyday basis. And surely if I could do that, then my kid would come home with art like this every day, like rainbows. And my art, our art did not look like this, by the way. And what I found is that I just wasn't given a lot of know-how or like specifics of, okay, growth mindset. Sure. What does that look like when they're coming home from school? What does that look like? What am I supposed to do at the dinner table? How many hugs am I supposed to give them? My cousin has this great little thing. It's like a family moral, ethical values and principles mantra that is on right by his door. It says like, we're good people, trying our very best, to contribute to the world or something. And then the kids walk in every day and they look at that and I'm like, oh, is that what I'm supposed to do? Am I supposed to get a mantra and put it right? And then will my kids turn out like wonderful human beings contributing to the world? Like, I don't know. Right. Or when I'm in that awkward shift between my kids, you're in charge of their lives and now they're in charge of their lives. And then there's a really awkward transition point. So I'm right there right now with a 10 and a 12-year-old. I'm like, how do I do that? At what point am I making their schedule versus they're making their schedule? And how do I do that? And there's nobody to really help me. You're just kind of figuring it out. And I found that to be the case with our approach to culture and suicide prevention too, where, as a field, we've made huge, incredible strides towards increasing cultural awareness and, just the importance of DEI work. That's probably why you all are here, is because you know that it's important. You're aware. And we've made huge strides in emphasizing the importance of collaborating with cultural communities, so that these efforts need to be led by cultural communities. But then we kind of seem to stop. And as a therapist, we stop there a lot as well, where we say, be aware of your biases. You need to create a comfortable cultural conversation and environment, and a trusting environment to have the conversation. Be aware, be inclusive, and then we stop. That's also my criticism, is that we stop there. The implicit message is that with awareness and representation, we're done. What's missing is the how. So, it's been unclear, how do we actually change our programming to actually be attentive to folks' cultural needs? So when you're doing some community education about suicide prevention and warning signs, well, but, are those the exact same? How do we change that? Right. So I'm really here to kind of be a proponent of the fact that we need an application of what we know about culture and diversity in a way that actually adapts and tailors all of our programming efforts. And then when we do apply, so let's say we figured this part out, and we do apply, because some of us absolutely, some parts of our field are absolutely applying. But the second criticism or gap, in my opinion, is that it's often piecemeal when we apply for one targeted group or the other. So I have multiple cultural identities. I'm sure every single one of us have multiple cultural identities. Sometimes being a woman is incredibly salient for me. Sometimes, when I'm teaching a class, my professional identity is incredibly salient. Other times, when I'm feeling, when I'm walking by, a place where I'm seeing a hate crime towards Asian American communities, there was one that that kept on getting reiterated. Anyway, in my community, then my Asian American community and its vulnerabilities are incredibly salient. So when you're creating, a brochure for women, and then you have another brochure for Chinese Americans. Well, I'm also second generation, very different than a first generation immigrant. So then you've got another immigrant related brochure. Then which one do I get, right? Which one do I get? And I think that becomes a resource problem for us. It becomes a practical problem for us, because we don't really know. Also, we're a diverse room right here. Everybody has multiple identities in this room. So which brochure do I hand out? And then I don't want somebody to not be spoken to in a mixed room, right? And oftentimes we're trying to educate the community, and lots of people come to one place. And what do you say? Like, oh, I'm using the Mexican-American adapted version of this. You're not Mexican-American. I'm sorry, you can't come in. Like, it's just not practical, right? And then we have this other issue of, well, that one may not speak to somebody else from another identity. And so we end up having this piecemeal application. And let me illustrate this barrier with another metaphor. So let's say you're trying to manage your diabetes. And you put in this really great effort. You start eating a meal that looks like this. Actually, our lunch today was really quite healthy, depending on how much sour cream you put on it, which I was like, and that huge thing of guacamole. It's still, is that unhealthy? Healthy? Really uncertain. I'm going to go with healthy. If I ate it, it's healthy. So you've got this, right? And you're like, yeah, I'm doing great. This is amazing. I've eaten this amazing meal. And then in the greater context of your meal plan, the rest of your day looks like this. You have chocolate cake for the rest of your meals and snacks. In the larger scheme of things, this just isn't a very effective or comprehensive approach to managing your diabetes, right? And so again, being facetious here, but in that same vein, this piecemeal application is not where we want to be. We want to, it's not very effective or comprehensive when we're really trying to reach everybody in our community. And so, the goals when we're talking about cultural infusion is we're really trying to put it throughout rather than having a piecemeal effort. And we really want to actually have guidance for application rather than having it sit in awareness. And that's been, in essence, if you think about even just trying to manage a program and all of those resource barriers and difficulties, it's been tough. Like, how do you do that, right? How do you make sure that it's there for lots of people from different backgrounds all in one place? And so that was our mission. That's our mission for creating the BSBB, and then we created one for clinicians that's also culturally infused. That's called SP201. But in order to do that, so in order to solve those problems, what we realized in the very beginning is that you need a theoretical grounding for that. You need some kind of guidance for the principles that will guide that work. And when we initially did this work, like in 2008, I looked around and I was like, well, I also am very much, I have a part of my identity that's very much a researcher, and I love data. So I was like, okay, well, what does the data tell me? How do I do this, right? How do we do this? And I looked around and there was a ton of research. There's actually a ton of research on suicide prevention and different cultural minority groups, but it looks like this. It's like gobbledygook. And in my clinical hat, I was like, well, what the heck am I supposed to do with this? I've got, my client's in crisis. I have 15 minutes to figure out what to do. And I want to make sure that I'm responding in a culturally appropriate way. But I don't have time to do some lit review. And nobody's really taught me how to do this. And so the first thing that my colleagues and I did, we got a whole group together, and what we did was we just coded 20 years of empirical research. We're like, okay, I know it was terrible. I really wanted to lay down multiple times. It took multiple years to do that. I hope to never do it again. But what we found when we were thrilled to do is after coding that 20 years of empirical work, we found that 95% of it falls into these 4 factors or principles, and so when you say, like, how does culture affect suicide and suicide prevention, it is these 4 factors, and they fall along a couple of lines of. Today it's known as the cultural theory and model of suicide. So it gives you 4 principles for how culture affects suicide. The reason why this gives you the framework to be able to infuse your work. So I'm going to be showing you how we did it with what's called BSBB trainings. But the reason why this helps you infuse and to be able to speak to a room as diverse as us is that it gives you the cultural principles that underlie the group differences. So for example, we know that minority stress will put people at higher risk for suicide. And when you look at the average list of warning signs, there's no mention of discrimination, of homophobia, of fear of deportation. That is not on there. That there's nothing on there that says, if somebody has to serve as a translator for another generation in their family, that's minority stress. All of those things are minority stress, right? But different groups experience it differently. And what we do know is that will put you at increased risk for suicide, partly because it feels like it's out of your control. So when I train clinicians when we train clinicians, I always give this I like to give this example of when I was in the 3rd grade, and I grew up in Texas, and my community was predominantly white. And there was this guy named Greg. I always itch to tell his last name because I have a terrible memory, but he made my life really difficult as an 8-year-old, and so I remember his last name. Every day I got on the yellow school bus across the street from my house, and he would start yelling whatever he thought Chinese sounded like my way, right? So everybody's looking at me, and I'm getting on the bus, and he's like, ching chong, ching chong, anytime that I would walk on the bus. And my mom told me, I don't remember this part, but my mom told me that I came home and I said that I wanted to have blonde hair and have blue eyes. And I don't think she knew what to do with it, right? Very similar to not knowing what mental health difficulties were. I actually don't know how she responded. But if you imagine, that's not something that I could easily change. That's part of who I am. And when you feel like, why is the world treating me this way? And I can't change it, I have no control over it. And then imagine, fast forward, you're living in a particular neighborhood or a context where you're seeing other people like you treated differently or treated poorly, and you have this sense of despair that it's not going to change, I can't make it change, it's just hopeless. And that is why you can see minority stress being uniquely linked with having suicidal thoughts. So if you can get into that experience, that's why, minority stress makes people anxious. Minority stress also makes people more depressed, but it is uniquely linked with suicide. So when you're trying to create a training that applies to lots of our different experiences of minority stress in the room, mine may be different than somebody else's in the room. You can ask us, have you been treated differently because of who you are? And for one of us, it might be, that teenager that can't go to other after-school activities because her parent needs help translating from Spanish into English. That's her having different experiences, being treated differently because of who she is. Whereas for my father, he was the first person to be laid off from his work. The sole reason, or the biggest reason, being that his reports needed too much editing. On every other, and he has English as a second language, in every other domain, he was doing great, right? It's different for him as opposed to somebody who's looking on TV in the middle of COVID and seeing hate crimes directed toward their community. But you can ask that larger cultural question and then have folks looking out for that higher order cultural thing that speaks to a lot of different groups. I hope that makes sense. But you can do that for a lot of things. Like you can look out for stigma. And we've delivered community helper trainings speaking to stigma, and that looks different for when we did the community training with a group of Spanish-speaking moms who absolutely don't have access to services, very different than an LGBTQ plus group that also has a lot of stigma. And you can speak to the stigma and speak to lots of folks in the room when you look at the cultural experience. And the cultural theory model suicide identifies those main factors that are related to suicide that allows us to infuse these into trainings. And when we did this, we saw that those trainings speak to a lot of folks in the room, thus solving our problem, if that makes sense. This has been infused into like clinical work with measures. It's called the cultural assessment of risk for suicide. So lots of clinicians are starting to use that to incorporate different ways that suicidality looks differently for different folks. And if you ask questions differently, you look for different risk factors. I'm happy to share these resources with anybody. And then if you look at like a common list of suicide warning signs, you'll also see that you can put some of those cultural factors into warning signs so you don't miss it. So like this is a slide from the BSBB training, and you can see that the yellow highlighted ones are ones that map onto those 95% that the research informed variations in cultural suicide risk, like not having others who understand you. Discrimination or being treated unfairly because of who you are, feeling abandoned or betrayed, thinking others are better off without you. So when somebody is from a culture that's much more collectivistic in nature, then we know that more warning signs that interrupt your social network, or you think that you're a burden to somebody else, then you're going to be at greater risk for suicide than somebody who's from an independent culture or individualistic culture. And these are examples of different cultural variations and ways of how to ask about suicide that we try to now, when I teach someone to ask about suicide, I try to include all of these examples too. This first one is from one of my colleagues that works a lot with Native American communities. Have you ever wanted to give your life away? Very different than have you had thoughts of killing yourself, right? But yet, as a clinician, I was never trained to think of it that way. And we don't have very much research, honestly, on what are the different types of questions that we need to use to ask about suicide. So here's just some examples. Here's just an example, a hypothetical example of if you had a suicide prevention lifeline brochure that had a list of warning signs, and it's part of community education. You put on the cultural warning signs, you'd have a whole other row. So in some ways, and Santa Clara has been leading the effort to infuse these cultural considerations throughout everything they do, whether it be when they create a media campaign, they had a Vietnamese community advisory group to inform the way that they message around suicide awareness and then getting someone to help. If like someone who has high stigma, you wouldn't want a media campaign potentially, we'd have to test it out, right? To say, are you depressed? If so, call, and for a community that doesn't think about or doesn't emote as much, or they have high stigma, you might want to say like, having trouble motivating at work, call this, right? It's very different. It just depends on what is more culturally acceptable for them. The history of this partnership effort with Santa Clara County, which was later joined by San Mateo County, is that back in 2017, we partnered together with this goal of let's infuse culture and diversity throughout everything. Media campaigns, the brochures, let's make sure that the cultural warning signs are on all lists of warning signs. And then a huge part of the suicide prevention efforts were community education trainings. So community helper trainings. So the first thing that we did in the first year was to evaluate trainings for culture and diversity. We evaluated QPR, ASSIST, mental health first aid, youth mental health first aid, suicide to hope, and cognito. And we found that culture just wasn't the things that I talked about. It's not infused, and it was pretty piecemeal. So when it was kind of stuck on the end, and it was very trainer specific. Like some trainers would address it, other trainers wouldn't. So we tried to work with some of these folks to say like, hey, let's collaborate. Can we culturally infuse and change the curriculum? For some, it was a little easier than others. But long story short, after trying to work on that for about a year to infuse the current ones, we decided, I remember the meeting where we decided this, you're like, you know what, this is gonna take forever. Let's just create our own. So that's what we did. We decided to create our own starting in 2019. And we're like, that'll give us maximum freedom and we can just infuse the whole thing with culture from very beginning to end and take what we know is essential for community helper trainings and just make that. So for those of you who are, I'm sure that you all are here for different purposes. You might be here thinking, how can I make my efforts, or how can I make my efforts more culturally infused? Hopefully thinking about some of those cultural factors. Happy to share with you any of the papers that talk about cultural frameworks and ways in which you can infuse those principles throughout everything that you're doing. Or some of you may actually be interested in delivering a community training, and BSBB is something that you could deliver. Cognito is something that we weren't able to replace because it's like VC backed and it's some pretty fancy technology with an avatar that you talk to and interact with. So our workaround there was to create, unfortunately, but better than nothing, a module that after you take the Cognito training, then what cultural concepts do you need to know, when you're working as a teacher in a school and you need to account for culture. And so this is available to anybody who wants it, just ask. I'm happy to give it. This is two pages front and back, everything you need to know about culture and diversity and suicide and mental health in 2 pages. And so folks who would take Cognito in Santa Clara would get these 2 pages. And then we infused it into this clinician training. But what I'd like to tell you about is BSBB for suicide prevention and BSBB for mental health. So we created 2 trainings with this goal of let's have this infused, non-piecemeal, applied approach. And the goal really was the goal of the training is to detect possible suicide risk and connect them to appropriate help. So in my mind, if you just think about, I really am looking for impact and meaning in my life. That's what drives me. And so I often think about the fact that, the person who is so brave, they're in a community that you don't talk about mental health, you don't talk about suicide. They reach out to that one trusted person, and that trusted person has no idea what to do. And I imagine, let's create a training to talk to that one person and let's see if we can make a difference. And that could potentially make the difference, because I also realized like long ago that when you look at the numbers, folks who end up to see a mental health professional like me or my colleagues in my community, in my Asian American community, it's something around like 1% of folks who actually have a problem. And then only a portion of those folks decide to say something. And then only a smaller portion still decide to reach out. And then when they reach out, another smaller portion follow through. So on average, folks will reach out once and be like, not for me. And then they'll drop out. And then so folks who actually get treatment from my own community is about 1%. And so I realized, if I really want to affect change in the way that I wanted to, actually, we need to do more public health work. We need to do more prevention work. And so that's who I envision we're trying to educate. So you'll see that, if the cultural infusion covers all of these different things. It includes addressing stigma, disaggregating a lot of the suicide data and statistics, looking for cultural variant warning signs, attending to equity factors that magnify warning signs, and then teaching community members how to react in a culturally responsive way. So when you have conversations, it can be very different when somebody needs extra time. We know that folks who have less conversations in their community and lower literacy about mental health, they need more time to acclimate to the idea of even talking about these topics. And so you need to prep community helpers to be able to do that, to be more patient, to come over and do it again and again. Because a lot of community helpers will be like, I asked a question about suicide and I suggested that they get help. Well, they must have gone to seek help now. and change doesn't work that way, right? On average, it takes, even myself, I did not actually connect with a therapist the last 3 times that I thought I needed one, because I just kind of hum and hawed, and I was like, do I have time to reach out? Do I have the money? Is it really that bad? Even myself, who has very, very low levels of stigma, took me months, and then I was like, well, all right, I muddled through, I guess, right? But my quality of life probably could have been way better. So on average, people take a long time to think about it, especially from cultural communities or underserved communities. And so we talk to helpers about that so that they don't get discouraged and they're there for support. And then when you're referring, there's also a culturally responsive way to refer. So we include all of that in there. It's called the Be Sensitive, Be Brave for Suicide Prevention. Anytime that you can talk to any of the folks in Santa Clara about it. But the other thing that we wanted to do, so for any of you who might be playing a role in educating the community, these are the cultural codes that are present in BSBB and that I think should be present in any community helper training. So for those of you who are just like interested, well, how do I do this? This paper is under review. It hasn't been published yet, but we did another review of all of the literature around gatekeeper trainings or helper trainings, and found, just pulling from community wisdom, what have people put into community helper trainings? What content should be the core competencies? And so these are mapped onto the core competencies of a community helper training. And so we did decide to try to publish this so that other folks could use it, but it's a framework for cultural infusion whenever you're doing community education. So for example, any community helper training should talk about cultural factors. It should include and attend to different cultural beliefs about stressors, life, mental health. So like BSBB will talk about the fact that, if you have unemployment, let's say you have in the tech industry. So for example, we have a lot of layoffs recently, but the tech industry is interesting in its culture in that you're supposed to not stay at jobs for too long. That's kind of part of the Silicon Valley thing. And if you've stayed there for like, my tech friends tell me, like longer than 5 years and you're way stale, and you should have moved on a long time ago. And so the devastation and the cultural beliefs around unemployment or getting laid off are very different in that culture as opposed to my father. When he got laid off, he was supposed to be at shell corporation for his entire life. And that's a very different cultural belief. So we train folks to think about like, okay, there's, your friend's going through some stress. What does it mean to them that they got a bad grade? What does it mean to them that they lost their job? And so these are all the core competencies. I realize I need to talk a little faster. This is the evaluation data to show that that you can do culturally infused general plus cultural training that has significant change on all of the general plus the yellow cultural competencies with large effect sizes. And so the evidence basis for BSBB for suicide prevention is that folks learn how to identify warning signs. They're more ready to talk to others with about their suicidal thoughts. They're more culturally responsive. And I just wanted to show you just an example of what it looks like. So BSBB, it's be sensitive and be brave. It's very much like QPR, right? So your QPR is question, persuade, is refer, is you're talking to someone, you're referring them to help. That's the be sensitive and the be brave as well. Interestingly, the be sensitive, different cultural communities respond to that in different ways, but it's actually been a pretty good term to speak to lots of folks. And so in BSBB for suicide prevention, people recognize the warning signs, then ask about suicide, and then connect them to help and make sure that they're safe. They connect them with help and then also increase help connectors, meaning your safety net, so that you're not the only one that knows that your friend or your loved one is in trouble. And they do a lot of practice. This is just an excerpt from the workbook where they get lots of examples with cultural infusion along the way of different questions to ask about suicide in culturally responsive ways. And then they practice with different age groups. And so this is a script. This script came about when we tested it with a Chinese group. And the breakout discussion of like, okay, you just learned about BSBB, now go and do it. Pretend to have, just pretend that someone is in distress and pretend that someone is a helper and be sensitive and be brave. See the warning signs, connect them to help in a culturally responsive way. And it was very discombobulating to have not enough structure. And so they asked for a script, and it turns out that everybody benefits from the script. So it's now just a part of the training. And where, for this one, this is for a school-age child, and then they practice going through a script, and then the color tells them exactly what they're doing when they're doing it to kind of model it. And then they can practice a little more. There's a companion training called BSBB for mental health, because when you do good suicide prevention, you're also doing mental health education. And this one was really challenging and really fun to create, because what do you do in 2 hours? I forgot to mention that. We challenged ourselves to do it in 2 hours or less. And here's Mego. This is the meeting where we're like, hey, let's create our own. That was with me and Mego. We're like, let's do our own. This is it. We challenged ourselves to do it in 2 hours or less, because a lot of communities, if you imagine, like, they don't talk about suicide. They don't talk about suicide. They don't talk about mental health. And so a lot of folks who have multiple competing demands in their life don't have 1 to 2 days to go to a workshop. So a training that is mental health first aid, which is really long, you're just not going to reach a lot of folks. And you're disproportionately probably going to not reach folks who have less financial resources and communities of color. So we challenged ourselves to do this in 2 hours or less. And it was really challenging to figure out what that looks like for mental health. But we're pretty happy with where it landed. I'll just shortcut this, that the evidence basis is good. It's been delivered a lot. So if any of you are interested in being a BSBB trainer or delivering a training like this, or taking the principles and learning from how we created a culturally infused training, I'm happy to talk to you about it or show you, or you can talk to any of the folks on the Santa Clara team. But the evidence basis, this is the one that I'm thrilled the most about, is that you can actually move the needle on stigma and how inadequate someone feels if they were to have a mental illness in 2 hours. And I was like, oh my God, that made me so thrilled that you can actually move that needle after a couple of hours of conversation. I'm going to spend just a few minutes showing you a little snippet of what it looks like in BSBB for mental health. So we just did like an intro in the training about how to tell the difference between everyday stress versus a mental health condition. Because we found that when you start off with that, then folks are able to tell a little more like, well, wait, should I be concerned about John? Is this temporary? How do I know that he's actually in trouble, right? And so that is helpful. And then this is part 2, and I'm gonna go into trainer mode here. Okay. So let's first become familiarized with some more specific signs of major mental health conditions, not for the purpose of learning how to diagnose, but for the purpose of understanding what mental health symptoms may look like. Okay. So in this part, along the way, we're going to emphasize the ways in which culture and diversity can affect signs of mental health conditions. We do know that in different cultural contexts, signs may not show up in the way you might expect. And to be culturally sensitive, it's important to broaden our view of what mental health symptoms look like. So in just a few seconds, I'm going to ask for a volunteer in the room to help us read Larry's scenario out loud. So with these scenarios, I'm going to ask you to practice identifying the mental health condition that's described using a poll or a raise of hands. So let's first look at Larry, who's a 43-year-old Cambodian heterosexual cisgender refugee who uses the pronouns he, him, his. And so is anyone willing to read about Larry out loud? And I'm seriously asking for a volunteer. All right, thank you. All right, thank you so much. So I'm going to put up this poll. And so with Larry, I just want to invite you to think what might be going on for Larry. So what signs of different symptoms of mental health conditions do you see? So, okay, I've got some A's. Go ahead and shout it out. A, all right. Any other thoughts other than minority opinion? D, panic disorder? Okay. Any others? E, okay, substance use disorder. Should we just go for B and C too? Let's just go. Okay, so A was the first instinct, then I think it was D, and then it's E. All right, so let's talk that through a little bit. So for those of you who guessed panic disorder, you're probably noticing that Larry's body is reacting in ways that he doesn't quite like, right? My heart is beating fast. He has cold sweats. And absolutely panic attacks do often come with what I would say is equally likely for him, which is A and E, post-traumatic stress disorder and substance use disorder. For him, it is related to alcohol. So let's talk about that a little bit, just take a little bit of a closer look. So here's a few facts about trauma and PTSD. We actually know that many people will experience at least one trauma in their lifetime, and most people actually recover from trauma, but some people do get stuck in the recovery process. And when they do, when that happens, we say that they have PTSD. And that looks like a cluster of specific symptoms. It might include unwanted memories, dreams, nightmares, avoiding things that remind you of that trauma, changes in moods or thoughts, or being on guard. And PTSD can really affect your relationships, et cetera, et cetera. I'm going to fast forward here. But luckily, treatment is absolutely available. Lots of really well-researched treatment, both psychotherapy and medication, can be really important to prevent prolonged suffering. untreated or without help and support, some folks can be dealing with PTSD for a really long period of time. And so it is important, and absolutely recovery is possible. So you see how we're trying to address stigma as we go. I'm trying to say, hey, this is not a big deal. It's so common. Lots of people experience it. And so we're destigmatizing as we go, and we're doing this through interactive case practice, right? And then I educate about substance use disorders. You'll see that we always talk about how culture matters and the ways in which these symptoms appear. And then at the end, I say, let's also practice broadening our view of what mental health symptoms may look like by looking at a cultural sign of mental distress. So the tinnitus or the tinnitus, the ringing in Larry's ears is actually a common sign of PTSD in Southeast Asian refugees. So in Larry's cultural context, that PTSD may be showing up in ways that you didn't expect. And we may not, if we're not used to looking for that, we may miss it. And so we have 4 or 5 vignettes that people go that we run folks through, and all throughout the way we use the color blue to show them cultural warning signs. We use the blue to show them, look, you thought PTSD looks like this. Well, the science tells us not. Clinical experience tells us not. We talk about irritability in adolescence. We talk about how in older adults physical symptoms can be masking depression. Lots and lots of cultural examples that are extremely powerful and that lead to misdetection of mental health symptoms and mental health distress all over the place. I could cite lots of research that shows how our diagnosis will actually completely change when you look at it from a cultural lens. I need to wrap up in just 1 or 2 minutes and leave 5 minutes for us to just have any comments. Just so you all know, we've got lots of BSBB trainers, and we would love for you all to, do BSBB in your community. You can talk to the Santa Clara crew. Santa Clara has a whole crew that's able to deliver trainings, including Jen here and myself, and Mego can deliver, and any of you all can deliver too. There's a training academy. We just put it online. So we're really working hard as folks have asked Santa Clara for the ability to also do a culturally infused training in their community. And BSBB has now been translated into non-English languages. So through partnership, this is the process by which we've gone through for translation. Pretty methodical with lots of pilot testing, with the idea, and the idea was, here we have it in Spanish, in Tongan, and in Chinese. And this year, coming soon, is Vietnamese and Tagalog. Anybody who wants to partner, we're actually still looking for some partnerships for folks to help with the Vietnamese translation, trying to hit the major threshold languages of the county, and happy to share these resources with folks. One of the questions we wanted to ask in this translation process is this idea that you can have a culturally infused training that speaks to multiple people. How true is that? So, or did we need to actually, when we're translating, are we actually having to create that piecemeal thing again? Which we were hoping we wouldn't, right? Because we want to speak to, even if there's one person of a particular identity in a larger group, we want that training to speak to them and their cultural experience. And the cool thing is that it is stayed the same largely. The content has largely stayed the same, which is awesome. That means that we can use this training for a wide variety of folks from different backgrounds. The things that have changed as we translate are delivery modifications mostly. So the content itself stays the same. The way the trainer delivers sometimes has to be tweaked here and there. So like food and community building, the folks in the Tongan community, this is a picture of them delivering BSBB to the Tongan-speaking Tongan community in San Mateo. So huge shout out to San Mateo County folks who supported this effort. And they did homemade food. The whole feel of it is so different. They put up their Tongan flag in the background, wore a Tongan garb so that the cultural community could really feel trusting. And then this woman in the front her name is Leafa, and she is a respected elder in the Tongan community. It's a very small community. and they start off the training with her sharing a story about her family member who has struggled with mental health difficulties. And then after she shares, the whole room opens up, and they're like, I went, and I don't understand Tongan, but they were laughing about mental health conditions, and that they were telling me is it was just created a space where they could talk about mental health conditions in a community that just doesn't talk about it. So the food was it's essential. Privacy for the Chinese translation, we found that we needed to explicitly tell them they could turn off their videos and change their screen name if it made them feel more comfortable. And a lot of folks took us up on the offer when we were delivering it online. They needed more concrete examples. That was true when we did the Spanish translation too. Culturally specific resources like this, we needed to make sure that the resources are listed are like the Asian Net Lifeline versus 988, which I don't think they have Tongan services there. And then language choice. When you're translating, really had to think about, well, which word are we going to use that will speak to the community? But largely the content of the BSBB stayed the same. And then with that, I think I'm done. So thank you so much for coming. And we have a few minutes, and would love to hear your questions and comments. And again, I know that we're all here for different reasons, and anybody have any thoughts that you want to share or questions? Yeah.
I have a quick question. You did mention that the Be Safe training, it is now online that you could do it, or is it okay?
Yeah. It's online. Someone can do it from the comfort of their own home, which we've been finding, like in rural communities and in some communities where stigma is really high, they're preferring that because then they don't have to go to a group to see it. So BSBB for suicide prevention is now online, self-paced, and available. But mental health is still in the works. But it's almost done. It's almost done. Yeah. Any other thoughts, questions, comments? Oh yeah, so all of these trainings have been tested and validated for high school and up. But it's been validated for helpers of middle school and below. So it's basically for all ages, but the only thing that age-wise that we haven't tested out yet that we would love partners actually is making middle schoolers helpers themselves. So I do think I tested it out on my kid. I do think he was like, "Mom, it was all right." I do think that we can make middle school helpers. I think we have other helper trainings that have done that, but the language would need to change. But we've delivered it plenty to high school students. But for middle schoolers, we've been training helpers and parents and teachers of middle schoolers, not middle schoolers themselves. Yeah.
Do you think the way that we're screening folks into our system of care is culturally responsive?
No. In short, yeah. The question was, the way we're screening folks into our systems of care, is it culturally appropriate? And no, I do think we're missing folks.
Even like how we characterize how somebody meets medical necessity, do you think that's culturally responsive?
At PAU, we talk a lot about how people will have underreporting or overreporting and different reporting styles depending on lots of things, lots of cultural factors at play. And on average, our systems aren't doing that. They're not accounting for that. So you'll get things like folks being diagnosed as psychotic or having a psychosis, and when you look at a cultural lens, it's not psychosis, it's trauma. Or it's something else. And so, yeah, I don't think so.
Functionality, like how we define functionality and how that might look different in different communities.
Yeah, how do we define functionality? Absolutely, is also very culture variant. I think we're at time. So I'm actually going to take this offline and say thank you for coming. Anybody who has additional thoughts and questions, would love to talk to you.